thyroid. Okay? Hyperactivity of the thyroid. I don't know if the book defines toxic goiter in there, so that's why I kind of, like I said, I'm using like 3 books to make my lectures, so I want to make sure we cover everything. Okay? But most of the information is coming out of your book, though. Okay? So non-toxic goiter, meaning that my thyroid is functioning fine. I don't suffer from hyper or hypothyroidism. Yet still, my thyroid is abnormally enlarged. Okay, that's also simple, colloid, multinodular. Toxic goiter, meaning that I'm having that enlargement is causing my thyroid to be hyperactive. Okay. So I also have endemic goiter, and that occurs when in the geographic areas where the soil, water, and food supply contain low levels of iodine. Okay? This dietary deficiency causes hyperplasia and hypertrophy, meaning that it's getting bigger and can promote goiter formation. Okay? Because I'm not getting enough iodine intake into the body. Because remember, the thyroid is the only organ in the body that can absorb iodine. All right? Then we have sporadic goiter, meaning that it's a benign enlargement of the thyroid, but I'm getting enough. I live in an iodine sufficient area. It's just spontaneous, okay? And that cause is unknown. Okay? That's kind of like sporadic goiter, like spontaneous goiter. Not because I'm not getting enough. I'm getting the right salt, right? I'm getting the salt that you guys were talking about the other day. But in some way, I still got goiter. Okay? And that could just be like a hormone imbalance, I'm sure. It's just your body. It's your body. Just like when we're in the lab and we just start finding stuff with each other, how much stuff have we seen on each other since we've been in here? You know? Yeah, just in the lab, just kind of scanning and just like, man, look at that. Somebody got this. Somebody got pelviectasis. Somebody got this.
That's correct.
So what's the difference between sporadic and just the non-toxic?
Sporadic and the non-toxic? I guess it would be the nodularity. The nodularity would be on the non-toxic goiter versus the sporadic, I would say, would just be just that enlargement. Just that benign enlargement. Because even though when nodular masses can turn into cancer, they can have cancer cells within them.
You mean non-toxic enlargement? We see enlargement, but no signs and symptoms?
Yeah, no signs and symptoms. No signs and symptoms because your thyroid is functioning normally. Your thyroid is functioning normally.
And what's the source of the iodine? Seafood or something? The iodine source?
The source of iodine? Salt. Yeah. Salt is the main source of iodine, but shellfish and seafood have a lot of it as well. So, our clinical signs and symptoms for goiter is just when you see somebody, right? You may see somebody with a big neck, especially like a real thin person. You may see them that have that big neck. We already know that person has goiter or thyroid enlargement right there. Okay, anterior protrusion on the neck can become very large, and it can also put pressure on it can cause problems because it can put pressure on your surrounding structures in your neck, such as your esophagus, your trachea, your veins, your carotid, your jugular veins, and your laryngeal nerve. Okay. Usually people with goiter present with symptoms of hypo or hyperthyroidism. Okay. Again, this is where we kind of get into where a lot of these pathologies start to mesh and kind of cross over each other. Remember I said that before on the first page of the pathology, is that a lot of these pathologies kind of, have that similar appearance. Goiter is multilobulated and asymmetrically enlarged gland. It doesn't always have to be asymmetrical, okay? But a lot of times it is. That's when you will see somebody just have a big mass on one side, and it just be on one side sticking out the neck. But it also can be bilateral as well. Okay? Goiter also doubles in size to a massive enlargement in which the thyroid weighs a few hundred grams. Right, so, it can get really, really big. And again, like I said, it can cause problems if you, some people, especially like the older generation who don't like going to the hospital, don't want to have surgery and stuff like that, they'll really be suffering if they choose not to do something about it. Because it's not like they can give you medicine to make it go down. Okay. So these are some examples right here of people with goiter, and you see hers kind of bilateral goiter, and you see this one is like unilateral right there, and you can see, if you got to look closer, you can see the outline of the normal thyroid, right, in black. But then you can see the goiter, that enlargement. But also you can see this one is nodular. You see how it's all lumpy, nodular, kind of got that lumpy appearance. Okay. So that's our image of goiter right there, guys. Okay. Sonographically, and if you guys look at the slides, I'm always going in the same order. I'm telling you what it is. I'm telling you the signs and symptoms. I'm going to tell you what it looks like clinically, and then I'm going to give you the sonographic appearance, and then I'm going to go to the next one. Okay, so it's going to be real consistent. Okay, so thyroid gland for goiter is the appearance can vary and may involve both lobes and the isthmus. So it's for sure goiter when you know that you see a thick isthmus going all the way across. Or if you just see somebody with that enlarged neck, you already know. That's what it is. Okay? Because what does goiter mean? Simply enlargement of the thyroid. It's that simple. Okay? Ectogenicity, like basically when you have goiter, everything, it may vary. That's what this whole slide is talking about. The ectogenicity may vary. It may be isoechoic, hyperechoic, hypoechoic. So you never know especially when it's nodular, what that appearance is going to be like. Okay? When we're talking about goiter, we're basically talking about the size, right? We're talking about the size of it. Okay? Calcifications, fibrosis, degenerative cyst, and hemorrhage result in a heterogeneous appearance. Okay? All those things result in a heterogeneous appearance. Okay? And you may have all of this going on at one time in one man, in one thyroid. You may have all of these things going on at one time. Okay? So again, that's when I don't get into trying to measure the different parts of this thyroid. I'm just trying to measure the size. Again, I've had to do whole thyroids using a curvilinear transducer the whole time because that's just how big it was. I wasn't able to use a 12 transducer to look at that thyroid. Okay. It may present as poorly circumscribed or well-defined. Like I said, sometimes you won't be able to make out, the actual borders of those. If you're trying to measure something, the mass, or you won't be able to make out the borders, but sometimes it'll look really, really, really clean for you. So the thing about goiter is it has a variable appearance, and of course, when we're talking about goiter, we're talking about the size importance more than anything. So let's continue on that. When goiter is associated with any risk for malignancy, it's going to have these features right here. It's going to have hypoechogenicity, presence of microcalcifications. Y'all seen those little white dots? You're like, y'all seen a thyroid look like that? It looked like, they say how the liver had a starry night appearance. Y'all never heard that before? It looks like these microcalcifications. You see little white dots all across the thyroid. Microcalcifications. Okay, that's associated with some kind of malignancy, okay, or cancer. Increased vascular flow and irregular borders. Okay? Just like if you have, something that's nodular, like if you have cirrhosis, that means your liver is really nodular, right? It's probably, especially if it's advanced cirrhosis, that liver is not going to be smooth at the top near the diaphragm. It's going to be really lumpy all the way around. And you'll even see that it doesn't have that smooth appearance. It's going to look really rough. It'll kind of look like sandpaper. Look like a landscape or something like that. Okay. So these are my images right here. Look how thick this isthmus is, guys. Again, you can't even see that the isthmus is separated from the right and left lobes, right? It's just thickened all the way across. Thickened all the way across. And here's some unilateral goiter right there. So this is a really great image because let's say if you do have the unilateral goiter, you always want to show a midline image so that they can see that comparison side by side in the size. Right. You may even have to use, you know, a curvilinear transducer. Okay. And look how all these different kind of gray shades within this mass right here. Same thing right here. This is what I meant. What I meant, like right here. Even though this looks like this is just a mass right here, right? I still would measure that as a single mass by itself because I'm not sure that all of this isn't one mass, right? I can't, especially when I turn it transverse, how am I going to know that all of that isn't just a very nodular thyroid and I'm just going to measure this little piece right here. I'm going to measure the whole thyroid and, you know, the doctor going to call it, you know, what he sees. Okay? So this is my images for goiter. Yes, ma'am.
What is the borders of the gland?
Which one?
For this picture, yes?
Mm-hmm.
This is the mass, right?
I really think it's the whole thing. That's what I'm trying to say. Because as I'm looking at it, this is the only part. It looks like some regular tissue right there. Maybe I'm not 100% sure, but I wouldn't try to get into. You see the little border things right there, but that may just be a septation. That may not be an actual delineation of one mass to another mass. Okay, that may just be a septation. Same thing right here. All of this may be goiter, the whole thing. Okay, just like right here, you see how it doesn't look smooth anymore? It looks rough now. Look how hypervascular that is. Okay, associated with goiter right there. Okay, so that's our goiter right there, guys. Goiter. Okay. What's something I left in here? Sweet. Okay, I'll probably stop at diffuse. So this section right here, guys, I kind of added all of my diffuse thyroid disease and thyroiditis in the same section. Okay? Diffuse thyroid disease, that's going to include Hashimoto's, Graves, and it's going to include Graves' thyroiditis. Okay, that's subacute thyroiditis. All right. So, diffuse and thyroid disease and thyroiditis. Okay. Disease is characterized by diffuse involvement of the gland causing enlargement or goiter without palpable nodules. Okay. Sometimes you can have an enlarged thyroid, but they won't have that big bulge hanging out of their neck. But that don't mean they won't have an enlarged thyroid. Okay. Those conditions include Graves' disease, thyroiditis. Thyroiditis is a group of diseases characterized by inflammation. Okay. And some subsection of thyroiditis would be Graves' and Hashimoto's. You do have to know both of those. That's why I put them in there just like that. Okay? That's why I put them in there just like that. And you have to know their alternate name. Okay? And colloid or edematous goiter. Okay? So I'm going to start with Graves' disease. Like I told you, we talked about it again when we were talking about hyperthyroidism, but I want to come back, make sure I hit what Graves' disease is exactly. Okay? So again, if it's in blue, Graves' disease is an autoimmune disorder. Okay? It is the most common cause of hyperthyroidism. Okay? The most common cause of hyperthyroidism. I purposely put this stuff on the slide more than once so you guys don't forget these important things. Okay? Don't forget what's important. Okay? What happens is the immune system attacks the thyroid and causes it to produce hormones and oversecrete the body with hormones. It occurs 5 to 8 times more frequently in women than men because of the apple, like Dewey said. Lab tests will demonstrate, it's important, guys, lab tests will demonstrate elevated serum T3 and T4, but low TSH levels, low thyroid stimulating hormone levels. What's the other term for TSH? Thyrotropin? Thyrotropin.
Yeah,
Thyrotropin. I thought I heard it. I thought somebody said it. The thyrotropin is the other term for TSH. Okay, so it makes sense, right? I have Graves' disease that's associated with it being hyperthyroidism, meaning that the oversecretion of thyroid hormones. So of course, when they do my lab test, I'm going to have elevated T3 and T4 because I'm having lower levels of TSH. Okay, because remember the thyroid stimulating hormone is what's going to ask the thyroid to secrete our T3 and T4 hormones. Okay, so it kind of makes sense. So just think, if I have Hashimoto's disease, Hashimoto's thyroiditis, that's going to be associated with a decreased level of T3 and T4 and an elevated level of TSH. Correct? What?
My blood test, always, they're looking at the T3, they're like, oh, it was elevated.
We coming out the book with this one. Alright. You just weird. I don't know, something wrong with you. Something ain't right with you. Something ain't right with you. I'm just messing with you.
See, not in the book.
Okay, so our clinical signs and symptoms, guys, for goiter. Oh, I'm sorry. For Graves' disease, man, I'm gonna just change that title. That's Graves, supposed to be Graves' disease, would be hypermetabolism, right? We're gonna be profusely sweating. We're gonna have increased appetite. We're gonna have a hypermetabolism. Diffuse toxic goiter. Okay, patient will present with an enlarged thyroid, and they're gonna have their eyes popping out of their head. Exophthalmos.
Because something is built up behind the eye.
Right, the fluid, the tissues are swollen behind the eye, causing these eyes to protrude.
Yeah.
Okay. So that was Graves' disease right there, guys. Graves' disease again. Graves' disease again, associated with hyperthyroidism, correct? You know, that's an autoimmune disease. The most common cause of hyperthyroidism. What else I had on there? Yeah, that's it. Elevated T4, T3, but low levels of TSH. So thyroiditis, guys, is a group of disorders characterized by some form of thyroid inflammation. Okay? Whenever you see itis at the end of something, it always means inflammation. It has several causes. It can be because of bacterial or viral infections, postpartum, post-radiation ablation technique, drug-induced, related to autoimmune abnormalities. Okay? These are all causes for thyroiditis. Again, thyroiditis is the umbrella, and different diseases come up under that umbrella that inflame the thyroid. Okay? Usually results from hypothyroidism. Thyroiditis usually results from hypothyroidism. Okay? So we have three main types of thyroiditis that I'm going to talk about, that we covered in this book. Acute suppurative thyroiditis, subacute granulomatous thyroiditis, also known as Gland-Grave disease. Please know this. Please know this. Please know these three. Okay? That's going to be on the registry for sure. DQ. That's going to be on there for sure. And chronic lymphocytic thyroiditis, also known as Hashimoto's disease. Okay? You know me. I love having the alternate other synonym for that word on the exam. So please know though, just like in our physics test, I have synonyms for resolutions on there. So don't know your Lord and know your ladder. Okay? Because I already made that test. All right. So, a subacute Gland-Grave thyroiditis is caused by a viral infection of the thyroid. Okay? Know that main thing. It's caused by a viral infection of the thyroid. It has a gradual and fairly abrupt onset. It means it's going to come on pretty quick. Okay? And what some symptoms you're going to have is it's going to come on quick, and also going to have a short period of hyperactivity of the thyroid. You're going to have transient hyperthyroid. You're going to have a short period where your thyroid is over-secreting hormones for a short amount of time. Okay, you're going to have fatigue, tenderness, neck pain, and fever. All right. The inflammation usually resolves in 2 to 8 weeks followed by spontaneous recovery in thyroid function in 6 to 8 weeks. So you actually will get your normal thyroid function back.
Is that same as the Grave disease?
No, it's not the same as Graves. Not the same as Graves. Because Grave is a more of an autoimmune deal. This is an infection. This is an infection, and it's associated with thyroiditis. Graves is really associated with diffuse abnormalities of the thyroid. Okay? Diffuse enlargement of the thyroid. I put them all under one umbrella though.
It's only temporary.
Absolutely. That's a good word. I should have put that right there. Temporary. Temporary. Okay. And I'll probably stop after Hashimoto's. So, Hashimoto's thyroiditis, again, I'm going in on that. So, again, the most common form of thyroiditis is Hashimoto's, and it's related to hypothyroidism, correct? What's another term for hypothyroidism when it's severe? Myxedema. Y'all know when y'all see it, huh? Y'all know when y'all see it. Y'all lucky we don't have no oral test in here. Okay. Associated with autoimmune disorder, most often seen in young or middle-aged women. Goodness, ladies, I don't know what's going on. The thyroid does not like y'all. Okay. The lab test will demonstrate low serum T3 and T4 and elevated levels of TSH.
I don't know.
So that's Hashimoto's thyroiditis.
How does thyroid disease affect psychologically?
Depression.
If you have hypothyroidism, it can slow down your cognitive abilities. It can slow down your cognitive abilities as far as your mental development, especially if you have it like early. Definitely, it can affect your mental development early if you have hypothyroid. Say for instance, if we were talking about cretinism, okay, so that's also gonna affect your brain development as well, or your mental makeup as well. Okay, if you have hypothyroidism, you know, especially if it's like very bad, severe hypothyroidism, cretinism. And so definitely it can impact that. Here's our sonographic appearance for our thyroiditis. Sonographic appearance for acute or subacute is diffusely enlarged hypoechoic thyroid with normal to decreased vascularity due to edema. So this is the only one that's talking about decreased. We're talking about like Gland-Grave's thyroiditis is dealing with decreased vascularity, right? This is the only time we read or talked about anything dealing with decreased vascularity of the thyroid. Subacute and acute. Acute suppurative thyroiditis and subacute Gland-Grave's thyroiditis. Okay. And that's the appearance have right there. Guys, please study your images too. Please study your images too. May have pictures on the exam. Okay. Guys, I'll stop right there and I'll finish on Wednesday.